Hello. Thank you for tuning in today's Anticoagulation Forum webinar. The title of today's webinar is Personalized VTE Risk Prediction in Cancer Patients Using Clinical Informatics. I'm going to introduce our speakers. Our guest speaker today is Dr. Ang Lee, Assistant Professor at Baylor College of Medicine. He derived and validated this score in two different populations, and he's going to tell us exactly how this score was developed. If you have questions, please put your questions in the chat function of this Zoom, and we will answer them at the end of the presentation. Our discussants today are Dr. Kristen Sanfilippo, Associate Professor of Medicine and Staff Physician at Washington University of Medicine in St. Louis and the St. Louis VA Medical Center. We also have Dr. Marc joining us. He's the head of the Division of Hematology, Department of Medicine, Professor and Faculty of Medicine at the Ottawa Hospital, University of Ottawa. I'm Jean Connors, who I run Anticoagulation Management and Stewardship Services. I'm a hematologist at Brigham and Women's Hospital and Dana-Farber Cancer Institute. We're going to let Dr. Lee take the podium now, and I'm looking forward to his presentation. Dr. Lee?
Thank you. Thank you so much for the invitation to give the talk today. So I will be talking a little bit about the overview of the advantages and limitations of our modern curated electronic health records, or EHR, research, specifically in cancer and thrombosis. And then the subsequent part of the talk will be individual case studies about how we use natural language processing algorithms to classify and structure text for venous thromboembolism, or VTE, as well as the derivation and validation of this risk prediction model among cancer patients for VTE. And finally, we'll talk briefly about ongoing work for implementing patient-centered clinical decision support tools, and especially when it comes to pharmacologic thromboprophylaxis. So with that, let's get started. So first, I just want a quick introduction on this topic, why we care about this, and specifically cancer-associated thrombosis. And the audience may be is very well aware of the risk for VTE that occurs 7 to 9 times more in cancer versus non-cancer patients. The incidence of VTE certainly varies very significantly by the cancer type, and we'll show a little bit later on this part as well. And overall thrombosis, venous and arterial together, is the second leading cause of death in ambulatory patient with the cancer, along with infection. And finally, the mortality rate after thrombosis in patient with cancer is fairly high. So these are the reasons why we wanted to really be able to predict who's going to develop this and how, if there's a way to prevent this. So there are randomized control trial data showing supporting the use of selective anticoagulant, low-dose anticoagulant in selective high-risk cancer patients. And in this meta-analysis, when we pulled the data together, the overall reduction of VTE goes from 9% to 5%, and the overall increase in bleeding increases from 1% to 2%. Now, this is a very, very selective trial population for randomized control trials. So the question we always have is, can we somehow replicate this? Can we make this better? And can we make this practical in the day-to-day practice? We also did a cost-effectiveness analysis looking at, is this strategy treating for 6 months with a low-dose anticoagulant potentially cost-effective? Leaving some of the methodologies out of this, it essentially showed that the incremental cost-effectiveness ratio is about 12,000 per quality adjusted life year gain, which is considered cost-effective, at least in the United States standards, less than 50,000 per quality. So the existing risk models, we're very well aware of, at least the Corona score on the left-hand side. It's nice because it's very simple, and you can calculate the risk scores, adding up the integer points. And the only potential downside is that if you really run the score, only about 50% of patients will be classified as high risk. So we would still be missing quite a few people that would potentially be intervenable. And then on the right-hand side is a more modified nomogram that incorporates D-dimer into this schema as well. But the only problem here is that it's sometimes very challenging to get a D-dimer for patients who don't otherwise need a D-dimer. So it's the applicability of this work is a little bit less. So right now, I would say the chronoscore is still the most commonly used clinical risk models. And essentially a chronoscore 2 or higher is how the prevention trials have been conducted to select the high-risk population. So with that, we also know that, at least in the United States, that ambulatory pharmacologic prophylaxis is very rarely implemented in the cancer patients. And there's a number of reasons I list on the slide, from potentially the lack of precision to the fear of bleeding, the lack of time, the lack of awareness. And personally, I think there are ways to tackle this. And that's what we'll try to talk a little bit about, whether we can make a better model to make the exclusion more automated and provide some sort of support to the clinician so that they feel more comfortable and to align data with day-to-day practice. So with that, I want to step back a little bit to talk about how we actually derive the data from electronic health records, whether you use Epic or Cerner. Nowadays, we almost all use electronic health records for patient care, but how do we turn that into research? So looking at our patient population here. So I myself right now am in Houston, Texas. So you can see that Houston is Harris County, and our patient population is very different from the general US population. So that first thing is to make sure that whatever patient that we study in, that's going to be externally generalizable to the wider audience. So the hospital system we ended up using, so first of all, we looked at our Harris Health system, which is one of the largest county hospitals in the region, almost in the nation. It's reflective of our patient population here, but it's also very not representative of the United States population. And it's also very, very much uninsured, underinsured patient population, and a two safety net hospital system. And then, so as two of our external cohort validation, first of them, the second one really is the MD Anderson Cancer Center, which more closely aligns with the general US census than the Houston area. As we all know, it's one of the largest referral cancer centers. So the data from here, it's more reflective of the national demographics. And the third system we use to study our case is the VA National Healthcare System. And part of the reason for using that is it's one of the sort of the only one that we have good longitudinal follow-up and a national representation all over the US. But clearly it's a very unique patient population of veterans, predominantly male, and slightly different demographic than the US general population. So these are the three systems we use to derive and validate our risk score. And you might want to ask, like, why do you need to go through all of these? And I'm still in the process of getting more system and trying it out more in different places. And part of that has to do a bit with the sociodemographics of who goes where. So here's a concept of an area deprivation index. And this map shows you the red dots are the more deprived area, and then the blue dots, which is larger cities, is the less deprived area based on income, based on essentially poverty, housing, employment, and education. So that derives an area deprivation index. Now, if you look at these three different populations here, I mentioned the Harris Health, the HHS, Harris Health System, the Houston County Hospital. The median ADI, or area deprivation index, is 74%. So the majority of the patient in this patient population lives in poverty and have very little access to healthcare. So they tend to present with more advanced cancer and more challenging obtaining medication upfront treatment. The VA population actually also is more reflected with a higher ADI compared to the general patient population, and they also tend to live in more rural areas. On the other hand, looking at specifically within the MD Anderson patient population, they're actually do better than the median. So their ADI skews to the left. So they're less deprived or have more access to medical care and medical systems. And this makes sense to us because in many ways, where we end up seeking care depends on what insurance we have, right? And certain places will only accept certain insurances. And and then if your income and your ability to pay for that insurance and your employer certainly determines ultimately where you end up getting care. So it's important to, whenever we study these risk scores or different risk models, make sure it's externally generalizable. So moving on from there, what we did was we essentially looked at the cancer registry at each one of these three hospital sites, three hospital systems, and then merged that with the underlying electronic health records, whether that be Epic at MD Anderson Harris Health and the corporate data warehouse at the VA. And for each one of them, we attempted to essentially link the patient with an incident cancer diagnosis with one of these data tables that's shown on this list here. And just to break it down a little bit, here's our basic claims data, right? So there's the billing codes that we enter when we close the chart at Epic. We have to put the ICD code down. There's some CPT procedure codes that we can use. We have what we call structured EHR data. These are things that can be extracted from Epic. We can certainly find them in Epic Hyperspace, the graphical user interface we daily interact with. But on the back end, it's a bit more complicated, and you have to extract them out of different tables and then link them together. And finally, we have a bunch of unstructured data where these are very useful information, provide a rich source of information, but you can't really just use them and take them and start coding with them because they're unstructured. So we need some sort of natural language processing algorithm to glean information from these unstructured data. So that's really what formed the database, and we did this similarly at all sites to have a similar extraction from every place. And the key point here is that as good as our modern EHR system is, it still requires a lot of clinician validation and cleaning and curation of the data. Otherwise, there's a lot of junk in and junk out. So no matter what fancy method we end up using, if we can't be certain that data are actually reflective of what's going on with the patient, I don't trust it, and you shouldn't trust it either. So with that, what are health informatics or clinical informatics, and how does it take care in cancer care delivery or thrombosis research? You can certainly use it for methodology developments, research methodology, so machine learning methods to address health disparity research, to accurately phenotype a particular outcome. You can use it for research application to apply the models and generate a newer or better model. And finally, in a clinical application, you can create these clinical decision support to make it more user-friendly, unintrusive as a decision aid. So these are all different components and areas of clinical informatics that we can use and in combination with the clinical knowledge. So with that, I want to move on to the first scenario, which is talk about phenotyping for VTE and discuss a little bit about the epidemiology of cancer-associated thrombosis. So when we say phenotype, what we really want to know is, does a patient truly have a venous thromboembolism as how we would normally classify that clinically and for research definitions? Normally, all we have are these raw EHR data, and in this case, I use Epic a lot. But what we can do is come up with some sort of phenotype algorithm that can potentially inform this true state by using this raw data. And then we can use that to do our classifications. And to do this is actually a multi-pronged process that you need to identify the phenotype, essentially come up with a way to determine what is a gold standard. How do you want to define your outcome, along with the EHR definition and a specific algorithm and a set of plan of doing so. And then after doing that, we have to then essentially do a lot of chart review to determine the gold standard, and not only determine the positive predictive value, but in a way determine the sensitivity or what you'd be missing if you actually use your algorithm. So for this particular study, we define cancer-associated thrombosis as anyone with a radiology confirmed pulmonary embolism, any location incidental or symptomatic, or upper or lower extremity DVT, also either symptomatic or incidental. We excluded the splenic vein thrombosis and the unusual sites, and part of that because there's so much tumor thrombi, and it's really hard to differentiate which one is which, even with human reviews sometimes. So to determine this phenotype, again, we talked about the structured data, unstructured data. We ended up using a little bit of both because neither one alone was sufficient to actually come up with a valid phenotype for us. So for structured data, we reviewed a combination of ICD codes, the most common things people use for specific documentation. And you can see we use billing code and we use encounter diagnosis to supplement that, but we did not use problem list. And then we looked at the CPT codes to determine the radiology studies and as well as the anticoagulant prescribed to the patient for long-term treatments. And we came up with an algorithm where we define as anyone with the inpatient ICD code tends to be very accurate at time of discharge, 2 outpatient ICD codes the first time it's happening, or any ICD code with an anticoagulant medication within 30 days as our structured data algorithm. Now, on the other hand, for the unstructured algorithm, we use the radiology CPT code to define the type of radiology that would be relevant, Doppler contrast CTs and Doppler ultrasounds. And then from those reports, we extracted the impressions and essentially run a rule-based VTE algorithm that allows us to determine which one is a positive versus a negative statement to say whether someone does or does not have this event. We're currently in the process of developing a more a deep learning based model using a transformer machine learning model that can combine all the notes as well, so that we don't potentially get rid of the ICD codes, but that's a work in progress. So right now, we just did a combination of the ICD based approach and this NLP based, rule-based algorithm for running the radiology reports. So we looked at the validation for this first, and essentially what we ended up doing is selecting the 4 categories people fall into. If you're both negative, one of them is positive, or both being positive. And you can see if you're both negative or both positive, you're very good at positive predictive value here. But in the middle part, it can be very problematic. So if we were to do chart review, the middle chunk of people would be the ones I really want to focus on. So when we created this on a weighted sample to determine what the ultimate positive and negative predictive value and sensitivity would be, we came up with about a positive predictive value of 87 to 90% and sensitivity around 96%. By combining essentially these 2 separate algorithms to determine who does and does not have VTE. And one of the other caveat is this NLP. Hear a lot about it nowadays, but it's very system dependent. So if it's not, you can use what we call transfer learning. You can use what you develop in one system to another system, but you really have to adapt it and make sure that you use the right language for the second system, or you might give you inconsistent results. And over here, what we found, you can see the sensitivity got really low at the VA on its own, because a lot of the, you imagine VAs, many 130 plus hospitals, many different sites, the first radiology report is often done in a local ER before they are transferred to a VA hospital, and they wouldn't repeat it again. So when your algorithm only looks at that radiology report, sometimes you miss those people. So that's why every algorithm has its own sensitivity and specificity, and part of that depends on your data access as well. So with this, we felt pretty happy. We're like, close enough to get the outcomes that the way we want it to be. It'll never be 100%. This will never replace a prospective cohort study to really determine the outcome. But based on large data, this is considered acceptable at around 90 and 90% for precision and recall. So using that, we first look at the just overall incidence of cancer-associated thrombosis based on cancer type, as well as race and ethnicity. When we looked at it, about almost 500,000 veterans over 16 years. And what we found is similar to many, many other studies, that your cancer type is very important. So depending on what type of underlying malignancy you have, you can go anywhere from an incidence of 16, 17% down to something that's like 2-3%. And also there is clearly some differences by race and ethnicity. And it's very heterogeneous, and it's by no means uniform across all cancer types. And some of these have very small numbers, so treat the bars with a grain of salt, right? And so overall speaking, what we found is even after adjusting for many different factors here that we can think about, there is clearly still an increased risk for thrombosis in non-Hispanic Black patients versus the non-Hispanic whites, and a decrease in the Asian Pacific Islanders. And many of these factors, it's hard to explain fully what it's driven by, but there could be residual socioeconomic factors we're not able to adjust for, despite all of these other things we have looked at. So just some general trends and patterns here. And one of the, I guess I skipped that slide for the sake of time, but essentially there's no, we didn't observe any increased rate of VT in cancer patient over the last 15 years or so, at least in the US when we use the VA data. So that's somewhat reassuring. It's not becoming a new epidemic by any means. So then we will look at the VT risk prediction modeling and how we came up with a particular work. So we mentioned earlier that we created our 3 separate databases. For the Harris Health and the VA, I have direct access to these data sets. But for MD Anderson, I mostly work with my collaborators there, and they already have an electronic data warehouse, so they didn't have to recreate everything from scratch, where we had to do that at the other 2 sites. So we define our population as patient with first cancer diagnosis and receiving first-line systemic therapy within a year. We excluded them if they had a recent VTE in the last 6 months or they're on therapeutic anticoagulation, because we want to look for incident VTE in this patient population. And we assess from the time of index treatment, remember first line, right, until loss of follow-up, defined as a 90-day gap. If they're getting active treatment, I assume that they would be coming back to see an oncologist or somebody at least once every 3 months. So those are the assumptions that we baked into these cohorts. So obviously the big things here would be, you can see I excluded multiple treatment. It's only first incident cancer diagnosis. And a lot of that is driven by data accuracy issues. Part of the covariates I have in here is staging. And then that's extracted from the cancer registry, at least for the study here. And usually cancer registrars will extract information at time of diagnosis. So the farther you go along, if you're getting your second, third, fourth line therapy, the less accurate that initial data extraction will be. So that's part of the reason we restricted people with the first cancer getting first line therapy, just so we can have a more uniform cohort. And this will have some implication, and we'll discuss later on about the specific incidence of cancer-associated thrombosis, because this is sort of a higher risk cohort. Anyhow, so our derivation cohort is from Harris Health. Our county hospital system has about 10,000 people over 10 years. And using our computable phenotype, combining the ICD and NLP, we found a VT incidence of 6.2% at 6 months. Then we did the same thing at the validation cohorts at the VA. We found a little bit lower, about 5.1% at 6 months in this patient population. Finally, at MD Anderson, they actually had their own NLP algorithms. We just used that one. It's an institutional specific one. And that one detected about a 5.7% of ET at 6 months. And this one is fewer follow-up because they only converted to EPIC in 2017. So the next step we did was deciding what are the covariates we wanted to test in our models. And this part is where the clinical knowledge is important for initial variable selection. Nowadays, with more and more discussion on AI and machine learnings, there's a way where you can just throw everything that we have into the black box and have the model select whatever comes out on the other end. The only issue with that is oftentimes you have no idea why selecting certain variables and not others. And each time you use it, you actually have to throw in the same exact, all the data into it so that it can spit out the same data or a similar amount of data. So because of that, it makes it simpler to use a model when you still do some sort of variable selection and coming from a list of clinically relevant covariates. So essentially what we decided, it was like, well, we already have the Corona score. Why don't we use everything that's already done before? Clearly works. And let's add some other common well-known risk factors like the staging, the timing of treatment initiation, the type of chemotherapy you're getting, and maybe some patient demographics that we know are potential risk factors, and as well some comorbidities that would make sense to be potential risk factors. We added a few lab values, not a lot, just to look at the creatinine, bilirubin, ALT, and things like that. So from this list of covariates, I believe it's about 34. And we then essentially run a lasso, a feature selection model to select the top 10-ish variables so that we don't end up with all of them again in running the model simplified. And what lasso is sort of an intermediate between real machine learning and fake machine learning, or shouldn't say that, regression. So regression-based methodology for determining your model versus a machine learning base. And lasso kind of somewhat falls in the middle because it does do a bit of a penalization so that it prevents overfitting. And this fancy plots here, all it does is like it's telling you in cross-validation, if you run it multiple times, 10 different times, if you selected this number of variables here, and these top ones tend to give you a better prediction. So then you can see you don't need to go all the way, select all your 40-some variables to get a 0.7 AUC. You can probably stop somewhere from here to here. You'll be okay on that. So that's what this one is really showing, just showing your each covariate is one of these lines here that gets selected. So we picked the top 10-ish covariates, 11 I think is what we ended up choosing to have a trade-off between a complexity and fits. And that's what we ended up deciding on what our final model is. And all of this were done in only the derivation cohort. We could not, should not, and could not look at the data from the other cohort, or it wouldn't be a real validation. So we, after got the covariates from the initial lasso model, we refitted that into a logistic regression. So here you can see most of these are the covariates from the corona score, right? So BMI, WBC, hemoglobin, platelet, the same exact value. I did not change any of that. Wanted to keep it consistent. The only other parts I did change was I changed around the we changed around the cancer subtypes, because if you really look at how corona score was initially derived, it's in a predominantly solid tumor cohort. They have very selected patient cancer types because it's a cohort enrolled for studying GCSF really. So it doesn't have a lot of other cancer types. So when we use cancer registry, we end up capturing all sorts of weird esoteric cancer types. So in a way that gives us more chance to regroup them into appropriate categories. And one of the other parts we did is we sort of parsed out what is an aggressive lymphoma. Not all lymphoma should be in the lymphoma category. Certainly people with CLL, with follicular lymphoma, they probably don't have nearly the same type of risk for VTE as CNS, primary CNS lymphoma, or diffuse large B-cell lymphoma. So some of that can give you a more granular risk stratification by teasing it apart. So after happy about this overall classification, again, I try not to change the classification weights whenever it's possible, like the ones that are previously corona score kept at a similar weights, just to add an extra point for the colorectal group. Some of the additional things we found are cancer-specific and patient-specific. And these are specific covariates that we derive from the EHR, specifically staging, the type of therapy, which is actually protective if you're not getting chemotherapy or immunotherapy, history of VTE, lifetime, history of paralysis, immobility, recent hospitalization, and the Asian race being protective. So these are the ones we created the model, assigned some simple points, and added up the score. So anywhere from 0 to 5, we just rounded to 0 to 5. So testing this model out in each one of the cohorts using just the integer score, we essentially checked it initially for the derivation cohort. You can see here, it's fairly balanced between 0 to 5 on this distribution. And this is the overall VTE in the second column from 0.0 all the way to 0.5. And it's always going to look great in the derivation cohort, and because you can manipulate however you want, and you're allowed to do that in your derivation cohort. But then you just have to test it the way it is in the validation cohorts. And over here, our patient population is quite a sick patient population because of the patient demographics. So almost 50% of them would be classified at high risk, around a 10% at 6 months, and a C statistic or AUC of 0.71, where 1 is perfect, 0.5 is useless, and 0.71 is moderate, I would say. And then we did this at VA, and you can see this high-risk group already fell down a bit because their overall incidence is actually a bit lower there. So here we classified about 40% as high risk and 0.68 as a C statistic. MD Anderson actually, interestingly, very similar to the Harris Health cohort, 40% high risk, similar high risk percentage, around 0.71. So again, wanted to do this in different cohorts to ensure it's generalizable to different patients, different types of patient, different types of cancers. And then we also looked at each subgroup analysis by different age stratum, by race stratum, by sex stratum, and didn't really notice a huge difference in the discrimination for all of those. So here's a calibration plot. So what's important is not only to look at an AUC for these kind of studies. So you can look at AUC for discrimination, but it's also important to make sure that your model calibrates. And what calibration means is, let's say at MD Anderson, my cohort is derived at Harris Health. The same risk estimate, I want them to line up on the MD Anderson part. And they line up fairly perfectly because they're with similar different patient population, but they had similar risks. However, at the VA, you can see it undercalibrated a little. So if you go back to this slide, it makes sense because our higher risk group didn't go up to the 13%. We only observed 10% in the highest risk. So that's why I perform a bit less at the VA cohort, and the calibration is a little weaker there. So anytime we want to decide whether we want to implement a model or not, we need to check for its discrimination, and we need to check for its calibration. Otherwise, we may come up with the completely wrong numbers that we're giving people. So ultimately, everyone it's having to compare with the Corona score. So we did compare with the Corona score. What we found is this is essentially a modified version of the Corona score. So it ended up being concordant about 70 to 80% of the time. We did reclassify about 20%, 25% of the patient population. And most of the ones we classified from low to high risk, they were more closer to high risk than low risk. So we were fairly happy about this. And then more importantly, this really increased the percent of people in the high risk group, the 2+ group, from somewhere from 40 to 60% up to the 70% range. So that now we're happy about capturing more of the high risk group. And that obviously would improve your with your C statistic or that discrimination compared to the original Corona score. So that's the comparison over here. And then finally, we just created an online calculator based on the initial derivation cohort, replicating some of these covariates so people can go in and potentially type in the ones and see what you get. So feel free to play it out and give us some feedback on this one. Here's the link down here. It's the shiny tool. So in the last few minutes, just want to talk about what next and what does this really mean going forward. So a concept of dynamic risk modeling and implementation of patient-centered clinical decision support. So coming back to this part, we talk a lot about, okay, can we improve the precision of the model, right? Like, can we add all of this and make it more generalizable, make sure we test it in all different race and ethnicity and sex and everything. But that doesn't really address any of the other parts. People still don't know about it. They're not going to know about it. But they are busy. They won't do it. And people definitely still fear of bleeding. There's no question there. So these still need to be addressed. But before even going there, there's if you ever look at the epidemiology of cancer-associated thrombosis, we know it's highest around the time of diagnosis and time of treatment. So when we looked at our cohort, over time, the risk actually drops, and that just happens to the general patient population. Because of that, our risk score 1, 2, 3, 4, 5, 0 to 5 here also decreases over time. So there needs to be, even though the initial risk model was derived exactly right here at time 0 for all the cohort, we need to test it to see, does it work well over time? What if we say, well, I'm getting second-line therapy, I'm getting third-line therapy, and it's now like 200 days out. So you would still have similar risk factors, but maybe your overall predicted probability of having VTE needs to be lower, because that's the natural history of the disease. If you haven't had it in 200 days, you're much less likely to have it, even if you have a high-risk cancer, right? So because of that, your calibration needs to be changed. Even if the model itself does not need to be changed, it needs to be recalibrated to fit the scale. So that's something we're trying to figure out right now, is what is that dynamic scaling factor over time so that we can incorporate that into decision-making. So here's an example, 1, 2, 3, 4, 5 patients on the sheets that I provided from a recent data pool. And you can see, I'm just going to use an example, the last one, this patient with lung cancer, diagnosed over here on this day, right? And then started treatment shortly after, and chemoimmunotherapy, first-line lung cancer treatment. We gave it a risk score of 7 because it was really high-risk cancer and met all the risk factors. This patient did not have VTE at 180 days, but did have one a little bit later. So you can see that when we recalculate the risk score a little bit later down here is the next line therapy, just on the immunotherapy now, they still got a 0.6 points, and they did end up having VTE in this patient. So this score can change over time. The question is it valid for me to use the second one or the third one? Because I really only derive and validate it for the first one. So that's some work we're doing to see, can we make it dynamic? Can we incorporate additional risk factors? And ultimately, how do we build this out and use it in EPIC? That's also an ongoing work. But the way data flows here is essentially we usually extract data from the back end of EPIC, Clarity, and Caboodle. We created our risk models and calculate all of this, right? So this is my example of EPIC hyperspace, what we see. This is our relational database of Clarity on the back end. We link the data, potentially create a custom table here and link it back to provide some sort of data model visualization within EPIC that's incorporated. There's probably easier ways to do this if we can get access to the front objects of EPIC, but sometimes it's very hard for IT to release live data to us. So a lot of time we still deal with data warehouse data. So this is the overall workflow, and we've come up with a few different SQL extraction codes where we can try to do this without having to rely on human review. So when we looked at the treatment plan coming up in Beacon within EPIC, and selecting people with either recent, I think recent is probably better than future therapies, we can exclude people that we cannot determine some of these important factors. And then for the people without missing data, we can also actually implement a lot of the trial exclusion criteria. If you look at AVERT or Cassini, the randomized control trials, these can be done electronically, drug-drug interactions, type of labs, type of disease. Although the thing we cannot do is what we consider high risk for bleeding, because that's very much of a clinical judgment. And then from that patient population, which is about 77% of the initial starting cohort, we can then apply the risk stratification and provide some sort of risk stratified education to provider and patients. So that is the eventual goal for this type of work. And we're still working on this clinical decision support tool as part of a QI project, because we also expect people to not very much use this initially when you first push it out. So it's a work in progress going forward, but it definitely needs to involve not only physicians, but also nurses, pharmacists, and oncology providers to have a buy-in, physician champions, and people who actually do implementation science, as opposed to modeling, which is more of my expertise. So it's an ongoing work where I'm trying to collaborate with other folks here to move this forward. And with that, I think it's the majority of my talk. That's for today, and I would like to thank everyone on my research team. Could not have done this without all the supports of my collaborators, as you can imagine, through multiple different healthcare systems, and my mentors from everywhere, and all of my funding support too. So thank you guys for listening, and thank you, Jean, for the invitation to give this talk.
Wonderful. Thanks, Ang. Very, very impressive work. And I think, Marc and Kristen and I, and certainly you in the field, recognize that we see patients every day with cancer-associated VTE. And, it affects so many aspects of their lives, right? It can interfere with their chemotherapy administration while they're waiting to get, anticoagulation on board. It can interfere with plans for surgery, can make them anxious. I've actually seen patients angry. Why hasn't someone told me I could get a VTE? So, we know from data that it's associated with increased cancer-associated VTE is associated with increased morbidity and mortality. So when we look at the landscape of this, I think it sounds like you are just getting started in trying to implement this. Alok's score has been around for over a decade. Marc and Kristen, what do you guys think the barriers are right now? And how do you see us moving forward with this?
Well, I think Ang kindly highlighted some of the barriers. I think one of the important barriers, as mentioned, is the opposite side of VTE, but also the fear of bleeding. And we know patients with cancer have a higher risk of bleeding. We know this may change over time. We know the intervention will increase the risk of bleeding slightly. The absolute difference remains relatively small, but it looks like there's Ang has been very good at doing a lot of work on the VTE side of things, and we don't have all the answers on the bleeding side of things, and if that changes over time, as you illustrated. I know Kristen has done some work on that, and maybe she wants to move that forward.
Yeah, absolutely. I think that has been my focus recently, so that we can improve the incorporation of models such as Ang's in preventing thrombosis in this patient population. I know another barrier, aside from the fear of possible bleeding with the intervention in patients who don't yet have VTE, includes lack of knowledge. So improving kind of our knowledge dissemination through webinars like this. And I would say overwhelming on the primary provider side, on the oncologist side, who has to go over all the potential side effects of their implemented treatment, plus the prognosis, plus alternative steps. So I know some institutions like University of Vermont have instituted separate clinics to take some of that burden away from the oncologist and really give the patient-focused information on prevention of venous thromboembolism.
Yeah, no, and those are very important steps that we're going to get to in a minute discussing. I think on what struck me when you were presenting today was in the derivation cohort for all comers, the risk of VTE in an unselected population has been pretty static, say, over the last 10 years. So I remember when Save Onco and Protect, which were VTE prophylaxis trials that were in unselected ambulatory populations receiving newly diagnosed with chemo. And you're right on target there. And the argument back then was that, well, treating 6% with an injectable agent, even if you get a 50% reduction, the absolute risk in VTE is still low. Now you're really moving this field forward. And I would love to see, a question and answer about what do we think is an acceptable bleeding risk for any given VTE risk. And I know that may be the intersection of your work, Ang and Kristen, down the road, because it's that trade-off, right? We're always talking about risk benefit and how do we weight those? Do you have any insights, Ang, from your scores? Yeah. Would you, sit again? We always say, like, honestly, and to Kristen's point, I'm a hematologist embedded into a cancer institution, right? So I get asked about really complicated cases. Otherwise, I'm not brought in at all. And Ang, if you want to take down your slides so the audience can see all of us in full format, that'd be great. So how do you when we look at the patients that finally get to us, is there a way, Marc showed in AVERT a 2% risk with a DOAC, right? Easier to take than low molecular weight heparin. That's not really that high. So where do you think we should draw the line?
That's a great question. I think we have a lot of expert on the panel here, so I'll have them chime me in as well. But part of it is like, is it just the major bleeding that people care about? What about these clinically relevant non-majors, right? And that one is not just 1 or 2%, is much higher than that. So, and also, we'll have to remember, we exclude anyone who's going to likely bleed in clinical trials. We would never include them in clinical trials. But in day-to-day practice, what I've tried to do right now is just try to implement that exclusion. That exclusion exclude almost 25% of our patient population, actually. So then those are also, some of them are the high risk people, actually. So in many ways, if you end up doing that, it's okay if we want to follow the clinical trials. And ultimately, I think the bigger question is, we don't know patients' preference and what's more important to the patient. Is it a bleeding event or is it a clotting event? What if the clotting is just an arm clot in the line, and then so we actually, Marc and I have been talking about this and with Miriam, Dr. Kimpton and his group, about potentially looking into utility weights associated with clotting and bleeding from a patient perspective. And that's really the only way we can determine, like, not just general VTE patient. Of course, if you're going to ask a patient who don't have cancer and then a PE, like, how bad is a PE versus bleeding, they'll tell you it's terrible to have a PE. But if you have cancer, if pancreatic cancer, and then you describe to them, okay, well, this is what happens with PE, this is what happens when you bleed, you may get a different answer. So we don't know the precise part of that, and that data is really lacking. So we're talking about potentially looking into that as well, so that we can have better, more informed decision making into either a cost effectiveness analysis or just overall patient preferences for that.
No, and this is a great start towards I think making awareness. To Kristen's point, clinicians are busy in day-to-day practice, and if we can implement electronic alerts to notify patients of clinicians of increased risk, they might be more likely to prescribe prophylaxis. The implementation part, though, to Kristen's point, I don't know, Kristen, if you want to elaborate on just how busy you are, how hard it is. I know in our institution, we're always setting electronic alerts for various coag-related disorders, and people seem to just blow right by them. So do we think that that's a great avenue for using an electronic database and an alert to a clinician sitting in a busy practice? Love your thoughts, Kristen.
Yeah, absolutely. I mean, I think that there is a place for alerts, and there are some critical areas where alerts are needed. I think that on the outpatient side, we have improved alerts, probably, unfortunately, one of the areas where they're mostly present, that I think providers are getting alert fatigued, is prescription of medications. But outside of that, I think that an Epic tool that would allow visualization of a score like ONGS could be incredibly useful, especially on the oncologist side, because if they see, it's harder to ignore what you physically see. And so if there is some, imaging graphics that allows you to visualize the risk of your patient, I think you're much less likely to ignore that risk and discount it or minimize it when it's right there in front of your face. So I do think there's a role, and I think that ONG will be successful in figuring out how to implement it.
We were actually been talking about that. The last thing I want this to do is a pop-up, because I hate those pop-ups, right? So the first one I talked to the people was like, please do not make it a BPA. I do not want a BPA, like a best practice alert. It's not a best practice alert. I just want it embedded somewhere. You can put it on the storyboard. You can put it somewhere. If people want to look at it, they can see it, but I don't want it to pop up in their face. That part, I think we need to have better education about it. And if people are curious about it and they want to know, they will look at it and they can do something. But if they don't want to look at it, no matter what you do, they will not look at it, right? So that's my number one thought. And the number two thing was, I've been talking to someone else, Dr. Carlin Martins from actually now University of Vermont, about this topic. She's more of an implementation science person than I am. Just some of the stuff she's done previously, like don't do it on the first visit. Wait until it's the second visit, because there's too much to talk about on the first visit, especially you're just starting chemo. No one's going to be really into the mood of talking potentially about VTE, but then you still have the chance when they come back, when a toxicity check, talk about something else, supportive care. So make this more of a supportive care to talk about, rather than make it mandatory to talk about on the first visit, along with their numerous other things. Those are some potential ways to make implementation a little bit easier, but certainly not an easy task.
and maybe knowing.
No, go ahead, Marc.
I was just going to say, and maybe also knowing what the patient, as you mentioned earlier on, what the patients are thinking about it, because right now we make treatment decision based on case fatality, and we weight what's the underlying risk of dying from a major bleeding versus dying from VTE, and then we recommend trauma prophylaxis based on that. But it may be very different at a patient level, so understanding what they value and the utility of it will be very important, I think, to make sure that the oncologists are aware, because we know what the consequences of VTE or bleedings are, but oncologists don't really see that on a regular basis. So understanding how patients are seeing it, what their preference will be, I think will be important as part of the tool.
Yeah, no, these are very, very key points. And I think with regard to implementation, if you are stuck with a BPA, the issue of, like, UVM instituted a separate referral process with pharmacists, nurse practitioners, and other clinicians. And whether, when we look at the cost effectiveness analysis you did, for every one VTE, if you can avoid that, you save thousands of dollars, right? Tens of thousands. So, putting your money towards screening and saving that way, in hiring staff to take on that burden and take that burden away from the medical oncologist or surgical oncologist may be of significant benefit to all of us, at least in the US healthcare system, given our insurance issues. We won't talk about Canada right now, unless Marc wants to. But there are two questions in the chat that I think are pertinent, that I want to bring up, or a couple more questions. And so on this one specifically goes to your model, and how do you think the exclusion of thrombosis at uncommon sites, those splanchnic veins, is it tumor, is it clot, does that affect your risk assessment tool in any way? Is there anything, I would expand that to say, is there anything missing, from your model there?
Yeah, that's a great question. So we excluded the splanchnic vein parts because when we started looking at it, a lot of them were not captured by ICD code, but they were captured by our NLP algorithm. And there are a lot of them actually. So people don't document them, and some of them are just imaging incidental findings, and they're completely ignored. So we're talking about like we're actually writing a separate paper on this right now. About 10% of all of the events we found were splanchnic vein thrombosis, and almost the majority are from hepatocellular carcinoma, right? Your portal vein thrombosis from HCC. 20% of them have it. But is this really a high risk cancer? We don't usually think of liver cancer as a high risk cancer. And then similarly, some of the pancreatic outcomes is driven by the tumor wrapping around your splenic vein. So it's true, it's a thrombus, but it's not the typical, like most of them aren't even treated in our institution. So it's very difficult because there's the tumor invasion part, and there's definitely the tumor thrombi where it literally go into the vein. But even if it's not going to the vein, related to the tumor compression part, gets into where majority of the splanchnic vein are. So if we were to include that as an outcome in the overall CAT outcome, cancer-associated thrombosis, we probably would end up classifying certain GI malignancies even higher risk than we are now. Whereas if we don't include it, they're still high risk for DVTs and other parts, but it doesn't make it excessive risk. That's just my personal bias on it. I'm not sure that people with splanchnic vein behave the same way when it's related to the underlying tumor than the the inflammatory driven, pancreatitis driven ones we see in the other settings. So that's why we excluded them, just to not dilute out the outcome too much. And then we also did some additional sensitivity analysis focusing only on PE and lower extremity DVT, because I also know there are certain people that don't think upper extremity is real either, right? Like it's not as clinically significant as your lower and PEs. So I think those are all really important considerations. And I think we need more guidance from society to say, okay, where do we put the splanchnic veins for cancer? Are they part of CAT, or are we not going to include them? Because if you really start looking, there's a lot of them actually.
There's still a lot. I agree with you, Ong. There's still a lot of unknowns, right? If you look at the ACCP 2012, they said if it's incidentally found, they did not recommend treatment. It's only until recently that we had cohort studies and showing that there's a benefit for recanalization, decreasing portal hypertension, probably decreasing risk of bleeding, and having better prognosis. So we still don't know exactly what the impact of these clots are. So for the time being, probably keeping them separate, although clinically they're important, often we need treatment, but as a predicting tool, they may be very different and behaving differently and having different prognosis.
Yeah, no, that's an excellent point that both of you bring up, right? I mean, compression. I always tell my Dana-Farber anticoag staff that no anticoagulant is going to fix compression. And if you block flow, you block flow, and that's a very different mechanism. And so it may behave differently. Certainly propagation, and Marc, to your point, better recanalization, depending on the location of the vessel and the downstream effects, I think is huge. Someone had mentioned in the chat as well, or in the Q&A rather, why not include catheter associated thrombosis? And again, you could intuitively say that they are similar to tumor compression, or there's a block in flow due to the catheter being in the lumen. And is that a different mechanism? And does it, certainly I think they absolutely benefit from anticoagulation, but right. Predicting risk, right? That's a whole nother story. I think someone's going to have to, maybe you, Kristen, come up with a score just for catheter associated thrombosis.
We actually included that on our overall VT outcome. So when we describe overall VT, that does include upper extremity, which the majorities are catheter. And then we did a secondary analysis for PE and lower extremity only.
Right.
Yeah,
that's right.
And I think one of the questions more about why is catheter not a risk factor for it? I think that's potentially definitely a good question. And part of that has to do with how you define catheter. I won't get into it, but essentially the best way you can define it is with too much detail, CPT codes, right? And CPT codes are only outpatient billing. So you miss a lot of the catheter placed during the hospital stay, and you ended up with missing data issue. But maybe we can include it.
Well, no, it's a common occurrence that we need to deal with. One major question that I think everybody, I would love to hear Kristen, Marc, and even I will weigh in on this question about how reliable is the HAS-BLED score in assessing bleeding risk in patients with cancer-associated thrombosis. And I will even implore you to speak to any other bleeding risk prediction scores that you are aware of.
Well, I can tell you VA data. So we've looked at some of the available scores in VA data. We have looked at in the atrial fibrillation population who's on primary prophylaxis for prevention of arterial thromboembolic events, especially ischemic stroke. And we've also looked at the cancer-associated thrombosis population who has a new VTE and has started on anticoagulant therapy. And I can tell you that the scores don't perform as well as we would like to see. So kind of going back to Ang's presentation, you saw that he had some nice discrimination scores in terms of the accuracy of the scores in predicting the outcome of interest. When we look at HAS-BLED hemorrhages, orbit, atria, VTE bleed, even CAT bleed, which was specifically developed in cancer patients, although those on direct oral anticoagulant therapy on edoxaban, they don't perform as well. So we're seeing discrimination around 0.57 to maybe 0.61 or 0.62. And so I think there's significant room for improvement. If you think about some of these scores, you can kind of visually see, which also goes back to Ang's presentation, where he nicely pointed out that it takes clinical knowledge to develop these scores as well. And we have clinical knowledge about cancer unique risk factors where this population is going to be more likely to be exposed to certain medications that can increase risk of bleeding, may have a higher prevalence of cytopenias that need to be considered overall when looking at bleeding risk. So I think there is room for improvement.
Yeah, no, I completely agree. And although we referred to the Vermont Care model earlier, and I do think they use the HAS-BLED score to try to help provide some underlying risk of bleeding. I mostly use these scores to identify risk factors that are modifiable and that we can work on to ensure or try to mitigate any risk of bleeding if possible when we make a treatment decision about primary trauma prophylaxis in this patient population.
Yeah, no, much to consider in this population. The risk, as I alluded to before, the risk benefit calculation, we're still not quite there. Ang, I think this is a great start. I would like to see this implemented. I think Arthur Allen has a question about operationalizing the same logic to identify patients for the study to create a population health tool. And is that another mechanism, maybe not at the individual provider level, but if you have any thoughts on that, Ang, we'd love to hear them.
I've been trying to answer some of these questions too while here. So say sorry if they dropped off. I didn't realize. But yeah, so that's what we are trying to do with the operational perspective, and we are trying to do this on a patient level. There's actually a lot more considerations here too. Is like, when do you want to employ and deliver to the tool? Let's say if you can do it, do you want to calculate every single day? Like the moment their lab value changes, you're going to recalculate a risk score. Do you want to do it at the beginning of each cycle of treatment, or do you want to only do it when they change therapy? Actually, I'm curious what people think about in the panel. Like, when do you think people, like when you enroll people to the trials, right? Like Marc, do you consider it when they are switching therapy, like when they go from one line of therapy to the next line of therapy, or is it any time that they walk in and you say, okay, I'll calculate your risk score and decide to enroll you or not?
Yeah, it's a great question. We don't have a whole lot of answers, but certainly when there's a change in therapy, that probably would be a point. But you're right that there's different point of time in the cancer journey where patients will have contact with different healthcare providers. It can be like when they put a central line in, for example, or when they go to chemo teach. And when do you actually decide to assess the risk is $1 million question that we don't have the answer to.
Yeah. I mean, just for the audience benefit, you know, the Corona risk assessment score is using labs before initiating that first chemo, right? And you went to great lengths to make sure that that's what you captured in these cohorts.
Yeah.
But a dynamic, you know, fluid process, going to take a lot of programming.
Yeah, it's actually just deciding on that part makes a big difference, just because some people, if you even, so we don't want to implement any of these risk scores if they're not getting treatments. That's number one thing, because their risks are definitely lower if you don't require systemic therapy. And a finished therapy, I also think their risk is generally lower. So this is only for people who are still on treatment. But even then, it still determines, like, is this a continuously dynamic calculated score? Or is it something that it's an interval score that should be calculated each time there's a clinical change, that clinical change being the next line of therapy. And that changes your patient population, actually changes your overall risk profile as well. So this was additional things we're trying to figure out, so.
Well, on that note, we're looking forward to your work in the future, the work of all of you, actually, Marc, Kristen, and Ang in this area. So next year at this time, we hope to hear updates. I want to thank Ang, Marc, Kristen. I want to thank our audience here today. A few housekeeping notes from the AC Forum. The webinar will be archived on YouTube, and past webinars are also available. So for those of you who missed part of today's webinar, or for those of you who want to review some of Ang's great slides, please go to the AC Forum YouTube channel for further viewing. And someone just put the address in the chat. The AC Forum Bootcamp, last chance to register is October 12th. This is a compact 2-day event. It's virtually, it's held live, but virtually on October 13th and 14th. I know I have all my anticoagulation management staff attend when this camp is held. It is really fantastic, hands-on, great information, both background and how-to pragmatic learning, and that's available at the AC Forum website as well. And then finally, to our webinar sponsors and our audience who's still there, we want to thank both the sponsors and the audience for joining us. So thank you, everyone, and see you at the next webinar.
Thank you.